We're live.
All right, thank you. So good afternoon, everyone. Move ahead to call the meeting to order. And I'm sort of subbing in as chair on behalf of Secretary Sutters, as Faye Donahue was not able to join this afternoon. So the first item is just to approve the minutes from the June 21st council meeting. And we do need to do this by roll call vote. So I will just go around the room. Starting with, so Niels. Oh. Niels, I might have missed that. We have, I'll come back to you. Cassandra?
Approved.
Sandy?
Approved.
Colleen?
Approved.
Bill?
I believe I was not at that meeting, if that's correct, right? So I probably should not vote on those minutes.
Abstain? All right, thank you. Laura?
Approved.
Meredith?
I also missed that meeting, so I will abstain.
And I will move ahead and approve and go back to, let's see, Niels?
Can you hear us, Niels? Yeah, okay. I know we can't hear you. But we take it you approve the minutes?
Okay, all right. All right, so the meeting minutes are approved. And I will go ahead and turn it over to Ray to provide the executive director's report.
Thank you very much, Lauren. Welcome, everybody. We had actually hoped that we might be in person by this meeting, but one of the things we've discovered is we're not quite sure how to conduct hybrid in-person and remote public meetings. We do that sort of fairly regularly with staff, but the mechanics of exactly how to do that and how it would appear in a public meeting if a bunch of participants were in a conference room and therefore squeezed into a single box, we're going to get a better understanding of how to accommodate in-person and virtual meetings so that in the future we can, hopefully start having people in person. But without a critical mass, we thought it was best to continue with remote. So too bad we're not seeing each other in person, but we do what we can. Okay, so in terms of the executive director's report, just a couple of things. Since we last met, CHIA has started. We've had a phased approach to returning to the office that we rolled out starting in the spring. We went to phase 2 over the summer. And just this week, in fact, we've started phase 3, which is 2 days per week in the office. Pretty much everybody in on Tuesday and then one other day per week based on their team. And we've narrowed the exemptions for folks that do not have to come in. So it's increased substantially the amount of folks in the office today. It really feels like the old days. So we've started the kind of the return to work in a more complete way just this week. And so far, so good. So we'll let you know how that goes. Also, since we last met, CHIA's budget for fiscal year 23 has been approved. So we closed out fiscal year 22 with a balance. We ended up not needing to use as much capital money as we had originally anticipated. And the Executive Office for Administration and Finance and the Comptroller were very helpful with us in doing all the things necessary to kind of tie out our operating and capital expenditures. Our fiscal 23 budget looks good, and we're in the process of making all of our plans and finalizing what we'll be doing with those funds. I don't know if folks have any questions. We can do sort of a more detailed presentation at a upcoming session, but for now, the top line number for fiscal 23 is 32.4 million is CHIA's appropriation, and as I said, we'll do our very best to use it wisely. All right, so that brings us to the last thing that I wanted to mention as part of the executive director's report. And people, I know are aware of this, but I haven't been speaking about it much. So in some ways, it could come as a surprise to some. But my second term as executive director of CHIA expires on November 5th of this year. And much as it pains me, I will not be seeking reappointment. My wandering career path dictates that I do another stint in the private sector. And so my tenure at CHIA will be wrapping up in November. And I just wanted to acknowledge that and say that this is my last Oversight Council meeting, and I've really enjoyed working with you folks. I have a short statement that I want to read, just because if I try to remember everyone to thank and everything that I wanted to say off the top of my head, I would no doubt fail. So let me just briefly read a statement and then we'll move on with the rest of our agenda. Okay. And it's not my style to read statements. I typically am an off-the-cuff speaker, but as I said, I want to make sure I don't forget anything. So my second term as Executive Director of CHIA expires in November, and I am not seeking reappointment, which means this is my last Oversight Council meeting. On this occasion, I would like to make a few brief remarks. First, I want to thank Governor Baker, Attorney General Healy, and Auditor Bump for their confidence in appointing me to this position and for their support throughout my tenure. I want to thank the members of CHIA's Oversight Council for their advice and guidance over the past 6 years and for their willingness to contribute their time and expertise to serve the public interest. I particularly want to thank the Chair of the Oversight Council, Secretary Mary Lou Sutters, for her leadership and support. I want to thank the Legislature, the Ways and Means Committees, and the Executive Office for Administration and Finance for working so closely with us to understand our needs and for providing us with the resources necessary to do our work. I want to thank the hospitals and health plans of Massachusetts, who not only provide CHIA with the bulk of its data, but who also fully fund CHIA through annual assessments, resulting in no net cost to the taxpayers or the general fund for all the things we do. I want to acknowledge the work of CHIA's predecessor agencies, the Rate Setting Commission and the Division of Healthcare Finance and Policy, and all the people who worked at those agencies and at CHIA over the years. I specifically want to thank my predecessor, Aaron Boros, for the excellent work he did during his time at CHIA, and particularly the outstanding team he assembled, and which I was so fortunate to join. Lastly, but first in importance, I want to thank my CHIA colleagues. I want to thank members of the executive team specifically, but also everyone at CHIA, both managers and union members. You've been a great group of people to work with. Thank you. Thank you for being so welcoming and supportive, for the outstanding work you do every day, for exemplifying the spirit of public service, and for making Massachusetts a healthier and better place for all its residents. Finally, I want to say a word about CHIA. No other state places as much emphasis on measuring their healthcare system as the Commonwealth of Massachusetts. This commitment to evidence and facts has served this state well. CHIA's data and analysis are used by the legislature, the attorney general, the auditor, every healthcare agency in state government, every healthcare system in the state, every health plan in the state, researchers, employers, and the public at large. Thanks to CHIA's work, thousands and thousands of actors in the Massachusetts healthcare system are able to make better, more informed decisions to everyone's benefit. It has been an honor and a privilege to be part of CHIA and to be able to contribute to the interesting and important work of this wonderful agency. Thank you. All right, so I did want to make a statement, so there it is. Thank you very much.
Ray, we should all say what an extraordinary job you and your team have done, and
Yes.
I think we're all indebted and grateful for your tremendous work. I know we all feel that way. I just happened to say it first, but a huge thank you to you. It just really transformative.
Thank you so much, Bill. I really appreciate that.
It was, and we felt constantly that there was a steady hand at the helm this entire time, enormous confidence in your leadership, and then watching what's been produced over the course of your time there. It's been extraordinary, Ray. Really, really been a pleasure to work with you in this role. Wish you the best of luck in the next phase.
Oh, thank you so much. I appreciate that, Laura.
Yes, and I just want to echo the remarks and for Ray's leadership and always just being so collaborative, and your partnership and responsiveness to all of our requests. I don't think a week has gone by where EHS, particularly as a large user of CHIA's data, has gone by without us sending some fire drill of a request. And Ray was always there to step up and say, we'll make it work and we'll get you what you need. So really appreciate how responsive you and the team have been to what has been just I think a barrage of requests, particularly over the last couple of years, over the course of the pandemic. So I want to thank you and your amazing team for that.
Thank you, Lauren. I appreciate that.
I'll just quickly chime in and say thank you for extraordinary leadership and from the ANF perspective, you've done a really nice job of being careful and conscientious in managing CHIA's budget, which is very much appreciated. So thank you on that front as well.
Thank you. All
I
right.
have my thanks really quick. Ray, it's just been fantastic working with you. I can't believe this is your last meeting. Just to echo what Lauren said about responsiveness, you and the whole CHIA team have been ready to jump in with whatever ideas or questions or concerns the Attorney General's office and our healthcare team has, and you've been a terrific partner. So we're really excited to see what you do next, and thank you for your service.
Thank you so much. And I said I wasn't going to cry.
Ray, knowing you, I'm sure you're completely mortified at this point, but I just want to chime in as well and say officially from your sister agency, your friends at the HPC, what a pleasure it's been to work with you over the years. We're so proud of our working relationship with you, between you and David Seltz with our friends at CHIA. And you've built such a legacy behind you that I know will continue. You should be so proud of that. But thank you so much. You'll be absolutely missed. And please stay in touch with all of your friends in state government.
I absolutely will. Thank you so much, Colleen.
I'm just testing to see if you can hear me this time.
We can.
Excellent. Just wanted to also chime in and thank you, Ray. And as an end user agency, our collaboration and work on the APCD for the Division of Insurance has been instrumental. And so I really appreciate the leadership that you've provided in us being able to rely on the work that's gone into being able to produce a number of reports over the last few years. Has been very important to us. So I just wanted to share my appreciation.
Oh, thank you, Niels. That means a lot. I really appreciate that. Serving other agencies is really, it's our highest calling. So, well, thank you for those remarks, everyone. I really appreciate that. Yeah, it's just a great job, and this will always, my time here will always be very deeply meaningful to me. So thank you so much. Onward we go. There's a lot of work to do. There's a lot of interesting and important work. So let's focus on the future. So let me think, Alex, in terms of the slides, are we at the point now where we show slides? Okay, that's what I thought. So I wanted to, I will turn it over now to Emma Schlitzer, CHIA's External Affairs Manager, for an update on legislative activities since we last met.
Thanks, Ray. It's tough to follow. So like Ray said, I'm going to provide a brief legislative update since our meeting in June. You can go to the next slide, Alex. Great. So since our last council meeting, the governor signed an act addressing barriers to care for mental health, also known as the Mental Health ABC Act. The new law focuses on mental health parity and increasing access to mental health services in Massachusetts. There are provisions that aim to address ED boarding, implement a new national mental health hotline, and mandate insurance coverage of annual mental health wellness exams and acute mental health treatment. In this new law, CHIA is tasked with including analysis of behavioral health services, specifically costs, quality, and utilization, among other measures in our annual report. We've already started planning for how to include it in next year's annual report by leveraging our primary care and behavioral health data collection and our other data assets. I also want to mention that since our last meeting, formal sessions have concluded and several pieces of healthcare legislation that we were tracking did unfortunately not make it across the finish line. This includes a Senate bill to address pharmaceutical costs, a House bill that would have increased oversight of hospital mergers and expansions, and the governor's legislation to increase investment in primary care and behavioral health services. We will continue to monitor legislation through informal session and begin to plan for the next legislative session, which will begin in January 2023. Go to the next slide, Alex. Great. If there are any questions, I'm now going to pivot to walk through publications that have been recently released, followed by a look ahead to what's coming up next. So since our last meeting, we have released a quarterly hospital financial performance report with data through the end of March 2022. In July, we published the results from the 2021 Massachusetts Health Insurance Survey, or the MHIS. The MHIS is one of CHIA's biennial surveys. It's population-based, and it provides information on health insurance coverage, healthcare access and use, and healthcare affordability. It's also used to determine the uninsurance rate in the state. Also in July, we released a provider quality report and a relative price update with calendar year 2020 data. We have also released a quarterly update of hospital inpatient discharge data, or HIDD, with data through March 2022. These quarterly updates use interim data to present analyses on a monthly basis to provide timely patterns and trends on key inpatient utilization measures. And as you may be aware, we published today our first report on primary care and behavioral health expenditures in Massachusetts, which you will hear more about shortly from Erin. We also completed 2 mandated benefit reviews focused on mental health parity and dual diagnosis treatment. And then lastly, we released an edition of our newsletter Data Matters, as well as 2 data releases from our case mix databases. So now moving ahead to see what's coming up in the next few months, we have 2 hospital financial performance reports forthcoming, the FY21 annual report and the next quarterly report, which will have data through the end of June. We will also release 2 reports from our HIDD database. In addition to a quarterly update, we will publish a full report with key measures of inpatient utilization overall and by hospital, patient, and discharge characteristics for federal fiscal year 2020 and 2021. Also upcoming is the Behavioral Health and Readmissions Report with FY20 data. The report will provide an updated analysis on the prevalence and readmission patterns for individuals with comorbid behavioral health conditions discharged from Massachusetts acute care hospitals. And then lastly, we are working on 2 mandated benefit reviews, which are on track to be completed in November, as well as the next edition of CHIA's newsletter Data Matters, which we plan to release at the end of the month.
All right. Thank you very much, Emma. Next, what we're going to do is show the Oversight Council the summary of the primary care and behavioral health expenditure report that CHIA just released this week. This is really exciting work that we've done. It was a couple of years ago that the governor filed legislation to require providers and payers to increase investments in primary care and behavioral health. And when the Executive Office of Health and Human Services asked CHIA and the HPC what data we had on this subject, I was surprised at how little we were able to say about the levels of primary care and behavioral health spending. And so even though the legislation that the governor filed didn't pass, it's within CHIA's authority to collect and report on this type of phenomenon. And so we decided that it would make sense for us to move forward. Should legislation pass, we would have a couple of cycles under our belt of collecting the data, and the submitters would have a couple of cycles of submitting it. There'd be more information on the table for considering public policy. And even if there is no legislation, we think it's a good idea to understand trends in spending for these 2 crucial dimensions of our healthcare delivery system. So we're very proud of this work, and Erin Bonney has been leading it up for us, and she's done a great job, and now she'll present some of the findings to you. So over to you, Erin.
Thanks, Ray. Good afternoon, everyone. So as Ray and Emma mentioned, we have a couple slides just on the primary care and behavioral health expenditures report that was released this morning, I think a couple of hours ago. And happy to answer any questions you might have about the data collection or the report itself. So Alex, if we can go to the first slide. Great. So it's a little bit of background and context, which as Emma and Ray both mentioned previously. So in both 2019 and 2021, Governor Baker filed legislation to increase investment in primary care and behavioral health services. That those proposals would hold providers and health plans accountable for spending increases in these service areas. As Ray mentioned, state level data on both these areas was limited. And so in the fall of 2019, CHIA began the process of collaborating with stakeholders to develop a methodology and data specifications to collect this data directly from the commercial health plans. In 2022, Governor Baker signed legislation that requires CHIA to publish information on behavioral health costs, cost trends, price, quality, utilization, and patient outcomes, which, as Emma mentioned, we will be incorporating into CHIA's annual report. And in terms of the report that was released today, so the inaugural report covers calendar years 2019 through 2020. And the report materials include a chart pack, a data book, and also an interactive Tableau expenditures graphic where you can go and dig down into primary care spending, behavioral health, and play around with the data that way on our website. So on the next slide, so a couple things, just how we collected this data on the methodology, what's included, what's not included in this initial report. So data was collected, as I mentioned, directly from the commercial insurers. It was collected at the managing physician group level, and it includes both fully and self-insured populations for calendar years 2019 and 2020. The data was reported at a summary level, and spending on these services was allocated into mutually exclusive service types based on a hierarchical process. So the data submitters evaluated spending for behavioral health specifications and ran it through that logic. Whatever spending was left over was then allocated out into primary care service categories. And then what was left after those two was categorized as all other services. Behavioral health, when we talk about behavioral health for the purposes of this report, it's defined based on combinations of principal diagnosis codes, procedure codes, as well as place of service or revenue codes. And primary care was defined based on a list of procedure codes delivered by certain provider types. The data that's included in this report, again, reflects submissions from the commercial insurance carriers only. So no data from programs that are solely administered by public payers are currently included. So traditional Medicare or Medicaid fee-for-service are not reflected in this report. So Alex, if we could go to the next slide, great. So diving into a couple of the top level findings of this report, the report itself focuses on these three insurance categories. So commercial full, the Medicaid, MCO, and ACOA plans, and then Medicare Advantage populations. The populations that we're looking at currently represent about 70% of all reported member months in calendar year 2020. So for commercial full, what we're seeing here captures about 2/3 of total commercial membership. The Medicaid, MCO, and ACOAs capture about 1/3 of total Medicaid membership, and the Medicare Advantage represents 1/4 of total Medicare membership. The report itself is at this market level. So we focus on these three insurance categories. And the first thing that we have on this slide is that when we look at primary care and behavioral health services combined, the spending percentages were largely consistent across the 2 years for each of these insurance categories. So for the commercial full, it was around 14, just over 14% on these services combined for both 2019 and 2020. The Medicaid, MCO, and ACOAs were just over 25%, so 26.3 in 2019, 27.4 in 2020. And Medicare Advantage was around just under 7% in 2019 and a decrease to 6.5% in 2020. While the spending percentages on these services were consistent across both years, we did see divergent trends within that. So behavioral spending increased and primary care spending decreased from 2019 to 2020. Specifically, one thing within this slide in this market overview, we see that mass health spending on behavioral health services represented about 20% of total healthcare spending or total medical spending in each year. A couple of things to note there is that payers who reported this data reported that a higher percentage of their MCO and ACO members had a primary diagnosis of behavioral health compared to their commercial or their Medicare Advantage members. And that is one of the key components of the logic as to whether spending should be categorized as behavioral health spending. And then another thing to note is that mass health for the years covered in this report covered a wider range of behavioral health services and providers. Recently passed legislation, I believe, involves some parity for commercial population, but for the years covered in this report, Mass Health had covered a wider range of behavioral health services and providers. So if we can move to the next slide. Great, thank you. Within the commercial population, one thing that we did look at this year is looking at pediatric versus adult spending for those two populations. And when we talk about the pediatric versus non-pediatric numbers here, what we're talking about is payments to pediatric physician groups versus payments to physician groups whose primary patients are over the age of 18. So a pediatric physician group for our data specifications represents physician groups for whom more than 80% of members attributed to that physician group are under the age of 18. So it doesn't capture the pediatric population based on age, but it does capture payments to those groups that primarily treat members under the age of 18. This is only within the commercial. And what we can see is that for both primary care and behavioral health services, pediatric physician groups had higher per member per month spending than adult groups. We do see those same market level trends of increases in behavioral health spending and decreases in behavioral health, increases in primary care, sorry, and decreases in behavioral health from 2019 to 2020. So what we'll do now is we're going to dive into the behavioral health and the primary care services specifically. So on the next slide, we have for the three insurance categories that we're focusing on in this report, within behavioral health, spending was reported for a couple different service categories. And so this is showing the distribution of where those behavioral health dollars were spent, what types of services. So for commercial full claims on the left here, we can see that outpatient services represented 60% of overall behavioral health spending in 2020. Followed by inpatient services, and then followed by spending on behavioral health prescription drugs. Inpatient was around 22%, and prescription drugs was 15%. In case the text is a little bit small, I know that my eyes are not particularly great at picking up these decimal places. Similarly, for the MCO and the ACOAs, behavioral health outpatient services were the largest service category, representing almost half of total spending, 47% to be specific, followed by inpatient and prescription drugs. The difference that we see here in terms of the distribution of where behavioral health dollars are going is really on the Medicare Advantage, where inpatient services were the largest service category at just under 40%, then followed by prescription drugs and outpatient as the third largest service category. One thing to note here is that we talked about differences in the populations on a prior slide, particularly in relation to the Medicaid population. And when we're looking at this slide, one key piece of context is that for the Medicare Advantage population, dementia is included in the list of diagnoses. So services for dementia and other cognitive decline conditions would be counted as behavioral health spending. In addition to looking at where those dollars were going, we also looked at the spending on a per member per month basis. So on the next slide, we can see the overall per member per month spending, as well as the range of those PMPMs that were reported by the payers for each of these insurance categories. So as we noted in the overall market trends, generally we saw increases in behavioral health spending. So for commercial, that PMPM spending went from $32 in 2019 up to $36 in 2020. And the range was slightly wider than we saw in prior years. For 2020, the range in that spending was a low of $18 per member per month, all the way up to $49 PMPM. For Medicaid, we see the largest increase in PMPM spending at $105 in 2020. That's up from $97 in 2019. And the range went from $25 up to $120 PMPM. Medicare Advantage The overall PMPM spending was consistent at $19 for both years, and the 2020 range was from $11 to $22 per member per month. So moving into primary care. So again, we looked at the behavioral health services. We're going to dig into where those primary care dollars were spent, and we also have it on a per member per month basis. So looking at the 3 insurance categories, office type visits were the largest category of primary care spending for both commercial and Medicare Advantage. And this particular category declined from 2019 to 2020 in all 3 insurance categories. Within commercial, we talked about the pediatric versus adult spending a couple slides back. And for behavioral health, we see largely the same distribution of services between the pediatric and the adult populations. Within primary care, however, for commercial, we do see some variation in where those primary care dollars were spent. I think that broadly it lines up with what people would expect. So for pediatric populations, immunizations and injections were significantly higher than for the adult population. Looking at just payments to pediatric groups, 15.8% of spending went to immunizations and injections, and that's compared to 6.8% for adult groups. Preventive visits were also higher, about 37, just under 38% of dollars for pediatric patients were for preventive visits. That's compared to 29% of adults. Conversely, obstetric spending was significantly lower. It was less than 1% of pediatric groups versus 8.5% for adults. Looking at other data points here, just to pull out a couple things. So other primary care visits made up a larger proportion of spending for both the ACOA and Medicare Advantage and insurance categories. That category includes things like annual wellness visits and Medicare enrollment visits. So that was a little bit larger. And then one last thing to note here is that the Medicaid MCO and ACOAs reported a higher percentage of spending for non-claims. So this 17% on non-claims dollars attributed to primary care was primarily capitation payments. And moving to the next slide.
Erin, quick question on that
Yes.
slide, the last one.
Mhm.
Are we breaking out in any way when we talk about a visit? Does that include telehealth?
Yes.
It does. Okay.
So on
If I could just interrupt for 1 second,
Yes,
Lauren, I think, could you speak to, I think we're actually asking, so yes, we do, it does include telehealth visits, but I think in our upcoming data collection, are we breaking out telehealth in some way, Erin, or am I confusing with a different collection? Because we will be drilling in more and more on telehealth because it's obviously more and more interesting. But so yes, it's in there, and I think we're going to do more with it, right, Erin?
Yes, on both accounts. So services that are delivered via telehealth are counted here in both primary care and the behavioral health. One thing that we note in the report is I spoke about the increase in outpatient services and behavioral health, and a large part of that increase we believe was really driven by being able to deliver those services via telehealth. So telehealth as a modality of delivering both primary care and behavioral health services are included in these service categories. And then to raise second point, as part of our data collection this coming year, we are going to capture, we're hoping to capture more specifically what that spend just for telehealth was. So we'll still see it broken out into these service categories, but we'll be able to narrow it down. We're hoping to say, okay, here's how much was spent for behavioral health, and here's what that amount was that was delivered via telehealth.
Great, thank you, Erin. Thank you, Ray, for drilling down a bit more on that, because that really was getting at the core of my question.
Great.
And actually, just one more thing, sorry, Erin, because I mean, so we continue each cycle, we're looking to do kind of more and more. And so we're going to break out the telehealth visits more specifically, but I don't remember if Erin mentioned it earlier, but where Mass Health is going to be providing us with their primary care and behavioral health spending for their entire book of business. So while at this stage, we only have the MCO and ACOAs, going forward, we'll actually have the entire Medicaid program. So each cycle, we will be looking to do something to improve the, the quality or extensiveness of the data.
Yes. Thank you for the excellent sell on the look ahead, Ray. So staying in our retroactive look of 2019 and 2020, similar to behavioral health, we have primary care spending on a PMPM basis. The commercial full PMPMs ranged from $23 to $61 PMPM. The overall decrease was from $41 in 2019 to $38 in 2020. Medicaid, MCO, and ACOAs were largely consistent. There's a very, very slight decrease when you look at the non-rounded numbers, but we see here that PMPM spending was level at $33, and the range was from $16 to $70 PMPM. For Medicare Advantage, again, we saw this spending decrease from $54 to $46 in 2020, and the range was from $33 to $58. So our last slide on the data included in this report this year focuses particularly on non-claims. And so those are the payments that are made from payers to providers for things not on a claims basis. So examples are settlements from capitation arrangements. If there are payments for quality bonuses, P for P, things like that would all be in the non-claim spending. We do want to put the non-claim spending in context of the broader market. So as part of the slide as part of the graph that we see here on the top shows claims and non-claims as a percent of overall medical spending. So when we talk about non-claims, we're talking about 2% in the commercial market, about 1 to 2% for the Medicaid, MCO, and ACOAs, and about 5 to 7% for the Medicare Advantage plans. As part of this data collection, we asked the payers to allocate non-claims out into behavioral health or primary care as they were able to. So if a non-claims payment was made and it was for primary care services, we asked that amount be allocated out. Unfortunately, the feedback that we got largely is that this has been very difficult to do. Most payers were unable to allocate or be able to tell what amounts of non-claims payments were specifically for behavioral health or primary care services. So the majority of it was reported under all other services. Only one payer was able to actually allocate those out, and that's consistent with what we've seen in prior years. And so on the bottom, we have just the spending amounts of what was able to actually be identified and reported as primary care and behavioral health. So within commercial, 1.6 million was allocated to primary care services and 2.9 was allocated to behavioral health, but we see 356 million was reported as being for all other services. Similarly for the MCO and ACOAs and Medicaid, 48 million was for primary care, 4.7 million allocated to behavioral health. The majority of it, 29.5 million went to all other services. On Medicare Advantage, we see 6 million for primary care, I think even a negative amount for behavioral health, and then the majority reported as all other services. So this is an area, as Ray said, each year we try to do a little bit more, gain more insight. And so this year, this area in particular is an area we're going to be focusing on in future reporting cycles to try to get better insight into this. And so segueing into our last slide, I believe. So looking ahead to what the next steps are, just in terms of data collection and reporting. So next month in October of 2022, we'll collect data on calendar year 21. As Ray mentioned, We will also be receiving data from Mass Health on that population, additional details on spending for telehealth services specifically. And we also are going to be able, we also are hoping to stratify behavioral health spending by mental health and substance use disorder at an aggregate level. We have a link here to the data specification manual that we issue out to the data submitters, that links out to where that lives on our website. Looking ahead to reporting in March of 2023 will include some market level calendar year 21 results in CHIA's annual report. And then later we'll do a full primary care and behavioral health report that includes additional payer and provider specific results. So I'm happy to take any questions. We went through a lot of data and a lot of slides, but happy to answer any questions that folks may have.
I want to mention for folks that the emphasis on non-claims payments, it's because in a lot of states that have done programs to measure and incentivize primary care spending, one of the big policy issues has been how do you treat non-claims payments, and is there a way to attribute them to primary care or not? And some states, I think, have chosen to include all non-claims payments as being deemed to be primary care related, so that they can, have a consistent rule for counting them. I don't know, Laura, if you had any. I know that Rhode Island has done some work in this area, but it's an issue that each state has to grapple with, whether you want to treat it in or out. So that's why we focused on it, because the payers and providers, if there comes to be an accountability program, they will certainly want to know how it gets counted. But it's tough.
Yeah. Having not been in Rhode Island now for 3 years, working there in 3 years, I've lost touch with that particular nuance of it. But and I think it's actually really important to begin thinking about that and to be doing this sort of work. I have another question to follow up if there are no other questions on that particular issue. The question is, when we're talking about non-claims payment, can you give me again the definition of a non-claims payment?
Sure. So the definition is any payment made not on the basis of claims, which isn't particularly helpful. So examples are settlements from capitation arrangements, quality bonuses, P4P arrangements, and things like that. So any payment that is not made on the basis of a claim.
Okay. And I realize that in terms of looking at the type of coverage that we want to encourage, there are a number of sort of self-pay. And I can imagine how difficult it was to get the non-claims, that it's almost impossible to get something that might include not involving the insurance company at all. And I know that for many people, they are paying out of pocket for behavioral health because of lack of coverage. And so, but it just feels almost impossible to be able to gather that kind of data, at least through the mechanisms that we're familiar with and we have access to. Is that true?
Yeah, that's an excellent point. So as this data was collected directly from the commercial insurers, it only represents spending. It only represents payments for members that were able to access services and have those services covered by insurance. It does include member cost share. So to the extent that you were able to access behavioral health services and you had a copay for that visit, that spending is included. And we do have a page on member cost share in the report. But to your point, if you access these services outside of the insurance market because you were able to find a provider, but they don't take your insurance and you're paying completely out of pocket, that's not reflected here.
And I can't imagine how to gather that. I mean, it's just not possible with the current mechanisms that we have, I don't think. Survey maybe, but.
Yeah, I just got a chat from Andrew Jackmaw, CHIA's chief of staff, indicating that the Blue Cross Blue Shield Foundation has apparently taken a look at behavioral health services delivered outside of the insurance market. So I think there's been attempts to try to get an understanding of that, but it's definitely a blind spot for us. But what I find interesting is just what a small percentage of spending, in a market where supposedly there's a widespread adoption of alternative payment methods. Why is it that it's 2%? And what I speculate is that if you've got a contract that sort of does an end of year kind of true up, it must be paying basically on the basis of claims, which would show up as, sort of claims based. And then it's only the sort of the bonus or penalty at the very end based on performance that would show up as non-claims. Because certainly more than 2% of the business in Massachusetts, I believe, is in risk-based contracts. That just seems excessively low. So anyway, as we start measuring this stuff, it just, more and more issues are highlighted that we get to dig into. All right, any other questions on the primary care and behavioral health report? I will say this is just the kind of the high level findings. The report itself has more details, including slides that do a more breakout of year-to-year changes. That's what will be really interesting when we start trending this as we get more data in-house. And then also, as Aaron indicated, starting next year, we anticipate reporting payer and provider specific numbers. So you'll be able to see, specific primary care and behavioral health spending levels by organization. So, all right, anything else for Aaron? Or are we good? All right, well, thank you very much, Aaron. Great work.
Thank you.
And I will say the distinction, and it didn't, as we were creating the specification, it wasn't, you can't stratify everything, but it was actually the legislature, the bill that passed, but as it was working its way through, it directs CHIA to measure behavioral health spending, breaking it out by mental health and SUD, which are the two kind of major domains of behavioral health spending. And we actually didn't set it up to do that. So we are, kind of going forward, we're going to be breaking it out that way. So that'll be a really interesting thing to look at, is how much of the total spending on behavioral health, how much of it is related to mental health, SUD, or co-occurring the two conditions. So we're just going to keep learning more and more as we keep going forward.
This is really great work. Congratulations to the team. Another really important release.
Thank you. And as I said, we could have waited until there was a mandate. Well, there is now a mandate from the legislature for us to do this on the behavioral health side, but we just thought that it was made much more sense to start collecting the data so that everybody had it at their disposal, and we were just, had more familiarity collecting it, creating the specifications, same with the data submitters, so that we're just better prepared as a state to have these policy discussions. All right, I think then that brings us to our last agenda item. So Alex, if you want to bring up the slides again. All right, so we just wanted to do a little something to kind of acknowledge the fact that in November is CHIA's 10th anniversary. CHIA and the Health Policy Commission were both created in 2012 from Chapter 224 of the Acts of 2012, and took effect in November. And so this November is CHIA's 10th anniversary, and we kicked around a number of different ideas for what we would want to present, some humorous, some not, decided not to go the humorous route. We were thinking of maybe the David Letterman top 10 CHIA hits countdown list type of thing, but upon further reflection, decided that was perhaps not the right way to go. So instead, this is just a list of bullets. I promise to make this brief. I just want to tick off some of the high level, and this isn't, it's always very difficult to describe and to bucket CHIA's activities and without getting, either too granular or too theoretical. But this is just an attempt to do a shout out, if you will, to some of the things that have happened in CHIA's first 10 years that we think are worth recognizing. So with that, Alex, if you want to go to the next slide. So first, and these aren't in any particular order or priority, but I do think that any accounting of CHIA and its accomplishments would have to start with total healthcare expenditure measurement. We're the first state in the country to do that. It's really CHIA's core function, year after year, measuring total healthcare expenditures and total medical expenditures, and using that to refer organizations to the Health Policy Commission for further examination if their spending threatens the benchmark. Many states around the country are now trying to emulate this. California recently passed legislation to start doing this. So it's a very good idea and something that many states are now doing, but CHIA and the HPC were the first in the country. And so while others are trying to stand up their programs, we're starting cycle 9 or 10 or something like that. So it's just great that we were able to get out in front on that. Second, I just want to comment on the fact that CHIA, I think, has really come into its own when it acts as a center of excellence for interagency data and analytics. Each agency has their own data and their own analytic capabilities. So we're not the mass health data department or the Department of Public Health Analytics Department or what have you. But CHIA, I think uniquely among the state's healthcare agencies, our function really is to serve the data and analytic needs of the legislature, the Attorney General, the Auditor, the Executive Office of Health and Human Services, Mass Health, DPH, the GIC, the Health Policy Commission, the Division of Insurance. I mean, it's really, CHIA at its best is a center of excellence serving other state agencies. And that's, wasn't immediately clear, I think, when we were first created, but I think, that's fairly deeply into CHIA's DNA right now that we want to work with and serve our sister state agencies. Third, I would point to CHIA's very aggressive price transparency agenda. It took us a little while to get onto the playing field with this one, but once we did, our Compare Care consumer transparency site had sort of more price comparisons than any other state transparency site at the time. We released all of the data behind our price transparency site in a single spreadsheet, which we call Big Transparency, which no state had ever done, and I don't think has done to this date. What else? There was one other, our prescription drug report. While other states are debating whether or not they should identify the 20 top priced drugs or the 20 most expensive drugs in the state, CHIA has produced multiple versions of a report that identifies the top, I think, 50 drugs in the top 10 therapeutic classes. So I think we've been doing detailed reporting on the 500 most expensive drugs. So while other states are debating whether or not to report on 20, we've been reporting on 500. Okay, on to the next slide, Alex. Expanded financial reporting for health systems. CHIA's oldest function really is collecting financial data from provider organizations, using that for rate setting and other purposes. But as the healthcare system has evolved and become more complicated, CHIA's data collection and data specifications have evolved with it. So we now no longer look just at hospitals, but we look at healthcare systems, which includes hospitals and owned or affiliated medical groups. So we've continued to keep our financial reporting up to date to continue dealing with the challenges of the healthcare system. With all the pressures on our healthcare system these days, I think having a close eye on the finances of provider organizations is a very good idea. Next, health equity, health disparities, social risk factors, and affordability. I'm proud to say these are areas that CHIA has emphasized for many years. It's not something that we've started to get into just recently. Although having said that, we are devoting significant attention to how we can improve our data assets to do a better job of reporting on health equity issues. And so we're working to collect new data elements around race, ethnicity, language, disability, sexual orientation, gender identity, and other things like that, so that we can do a more effective job of reporting in these areas. But we've done a lot of it's been with our survey data, which tells us so much about people's access to care and affordability issues and things like that. So an area we're emphasizing, but it's also an area we've always emphasized. Measuring primary care and behavioral health spending, you just saw that, but I wanted to give that a shout out because it's such an important aspect of the system. And we are the first or second state to measure behavioral health. There's about a half a dozen states that have gotten to the primary care before we did. All right, next slide, Alex. Major statewide surveys. CHIA does 2 major statewide surveys, soon a third. We do a statewide employer survey, which gives us really good understanding of the employer-sponsored insurance market, so we can understand what employers are thinking, what they're offering, what their employees are doing, what cost control strategies the employers are considering. It gives us really good visibility into that crucial part of our insurance, health insurance markets. But we also do a household survey. 5,000 respondents, very rigorous, and that gives us really good insights into access to care, affordability, lots of stuff about affordability. Because that data we do collect race and ethnicity when we're interviewing people for the survey, we're able to break those results down by race, ethnicity, and even income and other things like that. Our survey team's done a lot of really good work, which you've seen some of, teasing results out of these sample sizes, so we can add more and more social risk factors to our analyses. And we are getting ready to stand up a third survey, which will be a healthcare workforce survey. CHIA does not regulate the healthcare workforce. There's a number of state agencies that do, but it seems that everybody only has a little piece of the puzzle, and what's missing is systematic measurement of the healthcare workforce. And so CHIA is in the process of standing up a healthcare workforce survey that will let us look at capacity, and in particular, the demographic characteristics of the workforce. Because as you get below the doctors, nurses level, a lot of the healthcare occupations, you're dealing with people that might have English as a second language. There's a whole bunch of workforce factors that are important to consider, and our team is interviewing lots of key informants right now to try to develop the survey. Steadily increasing report output. A lot of CHIA's peers around the country only produce a couple of reports a year. CHIA is now up to, it's around 20, it might be more than 20. It's been increasing, every single year. And we now produce just a, substantial volume of publications, as you get a sense of when Emma does the summaries each Oversight Council meeting. Number 9 here on the list, extensive data sharing. CHIA shares lots of data with state agencies and lots of data with researchers. It used to be a slightly, of the states around the country with an APCD, we're one of the few that actually allows external researchers to get access to it. I think we are one of the more sort of easier to access states, but it wasn't always as easy as it should have been. So we've invested a lot of time and effort making it easier for CHIA to share data, both with our sister agencies, but also with private requesters. And that's really started to pay dividends. Recently, our processes are much more efficient. But I should say, even though we pride ourselves on how much data we share, we're also very strict and make sure that we're very privacy protective. We have a very good audit program. So we both share a lot of data, but take very good care of it at the same time. Okay, next slide. And this is the last slide. Advanced data operations. CHIA, originally, but it was never simple. Data, especially big data sets like the APCD, are complicated. But things started out, I think, where there was kind of a not a siloed approach, but there's, each data asset required a lot of effort and attention kind of in its own right. But we've now reached the point where we're doing more and more things that cut across data assets. And the key to that is our de-identified master patient index. We've become very sophisticated at dealing with de-identified information, but also building essentially a statewide index of individuals, not named individuals, but just unique individuals. And we use that to do a lot of linking between different databases without actually having to share names and personally identifiable information. So it's really become a real area of expertise for CHIA. The next item, embracing data science, is something that we've been doing in recent years, really trying to invest in our workforce and offer lots of training and opportunities for people to upgrade their skills from more legacy approaches to more modern data science-based approaches. We've done a lot of improvements to our core data assets, in particular, a huge investment in our all-payer claims database that's now wrapping up, and we're in the early stages of operations. And also we expanded our hospital discharge database to include private behavioral health hospitals, private psychiatric hospitals. And then lastly, CHIA also did a whole lot, both kind of in our own lane, but also just platooning people to support other operations that were happening related to the COVID-19 pandemic. So that took, for the last 2.5 years, quite a bit of bandwidth on CHIA's part. So that's the list. I just wanted to take just a few minutes, as I said, to do a little recognition, if you will, of the accomplishments that CHIA has had over the 10 years of its history, and also to thank you folks for your part in making this possible. So I don't know if there's, it's not really a discussion item, but I did want to just, like I said, acknowledge the 10-year anniversary with just a couple items like that. So see some happy anniversary wishes. Thank you very much.
Yeah, I think that to stop for a minute and recap and think about it, I think we go headlong. We get buried in this, it's onward constantly, and we don't really take enough time to step back and look at the massive amount of achievements and the importance that CHIA plays in the state and how critical the outputs have been. So congratulations to the group for 10 years of just amazing output. And, it's growing all the time. The next 10 years looks even more amazing.
Exactly right. Thank you.
I just would also add, in a future-looking way, that I think one of the things that most impresses me about what you've done, Ray, is that you have built capacity at CHIA. So as sad as I am to see you go, I know that this work will continue. All of the incredible initiatives that you put in place to get people trained in data science to cultivate leadership in a really inclusive way will continue to pay dividends for the agency for many years. So thank you and congratulations for that work.
Thank you. Thank you.
Ray, I also would want to add too that I think that there's been a culture of anticipation built here, which looks ahead to needs and say, what should we be thinking about? So you don't wait until something is mandated. You're taking a look ahead and say, would this be important? And I'm seeing that it's replete through some of the work that you do as we constantly hear about a report, and then you're always thinking ahead and your team is always thinking ahead to what might be missing, what might be important for the next round. So I just see that constant evolution as something to be commended as well.
Thank you. Thank you. That is true. We really do try to, you have to keep focus on where the puck's going to be because there's some real lead times here. And so we do try to look ahead yeah, see what we can do to be ready in time. All right. Well, okay. So not a long meeting today, but that's fine. That's as it should be. And so I don't know if there's any other business, but if there isn't, we can entertain a motion to adjourn, which is a weird out of body feeling for me.
So moved reluctantly in terms of your last meeting.
Exactly.
Seconded equally reluctantly.
Wow. All right. Oh, actually, also more. I don't want to preempt your.
No, so we have a motion. I don't believe we need a roll call. And so also reluctantly, we'll move to adjourn the meeting. So thank you, everyone. And thank you to Ray and team for providing that really comprehensive roundup. Just to echo other comments, you've been able to accomplish a lot. And certainly, and also just to call out in the wake of significant budget modifications and downsizing. So I think really appreciate the work that you've done to keep all of these priority areas front and center, even amidst budgetary dynamics that were challenging. So again, thank you to you and the team for all that you've done and providing us with this opportunity to step back and look at all the accomplishments. It will certainly be missed, but I know that this is not fully goodbye.
Exactly.
Thank you for giving us the opportunity.
There's one thing I've learned: state government in Massachusetts, it's a small town. So I'm not really going anywhere. So I'll be seeing all of you, I'm sure. So, all right. Well, great meeting. Thank you so much for everything, folks, over the years and today. And I will be in touch.
Great.
Bye.